You're ready for estrogen, or you think you're ready for estrogen, but you don't know how to choose the right estrogen because there are so many options out there. Or maybe you've talked to your prescriber and your prescriber is suggesting a particular form, but you still have a lot of questions and you've heard of other options and maybe you're on estrogen and the questions just keep going round and round. So that's what I'm here for today. We're going to talk about the top 8 forms of estrogen. Yes, 8. And I don't mean the birth control pill. Yes, the birth control pill is an option, and it's totally possible the birth control pill was suggested to you because there is a synthetic estrogen in it. But that's not what I'm going to discuss. I am going to discuss the top 8 bioidentical forms because that's the question I get the most. Now, bioidentical means it looks just like the estrogen in your body. And I'm going to be talking about a particular estrogen called E2 or estradiol that's in your body. Bioidentical doesn't automatically mean compounded at a compounding pharmacy. So if you're not familiar, a compounding pharmacy is a pharmacy with a pharmacist and they make it specifically for you. Some people feel if it's bioidentical, it must mean automatically it's compounded. Not true at all. There are so many bioidentical options on your everyday pharmacy that you know and love, or even the online options. So let's jump into what are the different forms, what are the 8 forms, and a little bit about them so you feel familiar. First, though, why might estrogen be suggested to you, or why might you think you're ready? Well, the big FDA-approved reasons are vasomotor symptoms, hot flashes and night sweats. That's what it means. Vulvovaginal atrophy. So all sorts of things down there. And then the prevention of osteoporosis. Not all of these estrogen products do or are approved for all 3 of these things. And we use estrogen off-label for so many more things than that. We use estrogen off-label for all the perimenopausal symptoms. Can't sleep and brain fog and mood symptoms and joint pain. Oh my gosh, joint pain. There are so many reasons. So I wanted to show you the FDA reasons, but also really reassure you that we use estrogen when you're ready and if you're a candidate for so many things than that. Like there are 12 systems in your body and estrogen can impact all of them. All right, let's dive in with number 1, the estrogen patch. This is probably the most common you're going to see, you're going to hear about, you're going to get talked to about. You'll see it all over social media. It is quite literally a little patch. It looks like maybe a little teeny tiny Band-Aid. It's like a fourth, depending on like a small Band-Aid, but like a half or a fourth the size of a regular Band-Aid. And it sticks on very similarly to a Band-Aid to your skin. Now, I am talking about the estrogen only patch. There is a combination patch or a combi patch that does have progestin in it. Progestin is synthetic. So if your prescriber has said, I want you on this combi patch, do know it does have progestin in it. But if it's an estrogen only patch, then that estrogen is bioidentical and is available at pharmacies pretty much everywhere. We don't compound the patch at a compounding pharmacy. Now, the patch, you change weekly or 2 times a week, depending on the brand. And the dose is somewhere between 0.025 up to 0.1. So you may start really low at 0.025, not feel a thing, move up to 0.0375, you know what I'm saying? 0.05, 0.075, 0.1. So you've got room to go up and to go down. The downside to the patch is that if you have any adhesive allergies, then it might show up. I've also gotten anecdotal feedback from women who were like, I was doing really well with the patch. And then whatever pharmacy I was using, they must have changed generics. And this new generic, it's the same dose. Like, let's say it's the 0.1 version. And they were just getting the generic version, changing it twice a week. And all of a sudden they're like, I'm itchy, scratchy, breaking out in that area. Am I now suddenly reactive to estrogen? Ooh, like, I bet not. I bet the pharmacy switched the generic company they're buying it from and they have a different adhesive. So you can actually always go back and ask your pharmacy, like, hey, what was the name of the manufacturer that I've been buying this patch from? And if they say, well, 2 times ago it was A, and then like this most recently it is B, then now you know it's 2 different manufacturers, which I know is kind of a pain, but it is helpful for you to know what you can ask your pharmacy about. The other downside to the patch is that if you are a heavy exerciser, if you are a swimmer, if you are in a hot environment where you sweat a lot, that the patch may not adhere very well and it might slide off. I've been in plenty of Reddit groups where hardcore athletes or people in Phoenix, Arizona in August, my swimmers are like, what waterproof Band-Aid can I put over the patch? Which seems weird because the patch kind of feels like a Band-Aid in and of itself, but then you need something almost bigger and waterproof to stick over it. Which again, if you have adhesive sensitivities, you may be like, it's a lot of adhesive. I don't know that I want to do that. But it may also just be at certain times of the year or with certain sports that you do. And it doesn't apply to everyone. So just keep that in mind. The other thing that I have noticed about the patch is that like where you put it sort of matters for you. They suggest sort of on the back, low back, upper hip area or upper buttock area. You may feel better putting it in the front, like the low belly area. You may like rotating it around. And certain patches will tell you like, oh, we absorb better on the low back area. But for you, you may notice you absorb better when it's in the front as opposed to the back or vice versa. So your pharmacy or your prescriber might tell you a place to start to put the patch, which is great. But if you're not loving it or you don't maybe want to rotate it around, just talk to your prescriber or pharmacy and say, do you care if I rotate it around? Because I'm not sure that I like this. Or even if you have adhesive issues, by rotating it around, you may notice less adhesive issues. And I think that's really helpful. Now, next, number 2, we have the oral estrogen. This is like a capsule, right? It's a capsule of estrogen, a capsule of estradiol. Comes in a couple of different forms, like 0.5, 1, and 2 milligrams. You swallow it just like any other pill. The downside to it is that because you swallow it, when it goes to your liver, it slightly increases your risk for blood clots. It's not a massive increase. It is a slight increase. But if you develop a blood clot, then guess what? It's massive for you. So do note it is a slight increase, a blood clot. It does have a slight increased risk for a gallbladder disease. Actually, I would say slight to medium risk increase of gallbladder disease. Now, if you don't have your gallbladder, not a big issue. But if you have your gallbladder, then you would definitely want to pay attention to symptoms. If you get any kind of symptoms, sort of like upper right quadrant of your abdomen, if you have stones, they can be quite painful. They can kind of radiate to your shoulder. The pain will radiate to your shoulder. Nausea that kind of comes and goes. Like you want to be right on top of that. You also have an increase in what's known as a binding globulin. So a binding globulin is essentially a bus in your system that binds up hormones and things and drives it around. When you swallow estrogen, the liver increases binding globulin. So it will, because it's like, whoa, this increase in hormone, let's increase buses and bind them up. So you may notice a drop in like testosterone, or you may notice you have to increase your dose of the estrogen because you've increased the buses. And now estrogen has gotten on the bus, so it's not binding to receptors. And so you have to go up to the next dose. Just something to keep an eye on. Your practitioner is probably already aware of this, but I want you to know this as well. If you go on estrogen and you notice your testosterone dropping, there is a binding globulin you can test. Sex hormone binding globulin, SHBG. It also, oral estrogen, increases HDL, which is what we generally consider like quote unquote the good cholesterol, but it also increases triglycerides. We don't want to increase triglycerides, but it does also decrease LDL, which is what we kind of call the bad cholesterol. Those are kind of nebulous because they're obviously it's not exactly good. It's not exactly bad. There's a lot more to cholesterol. So if you're going to go on oral estrogen, with my patients, I always do a very extensive cardiovascular lipid marker. I want to know like particle count and size of the particle and another marker called apolipoprotein B. I want to get more in depth in what's going on before somebody does oral estrogen. I actually don't use a lot of oral estrogen, but I know it is very easy because it's just a pill you swallow. And it's very common conventionally to just be like, oh, you're perimenopausal or menopausal. Here, take this pill, right? Like just swallow this. It's fine. So if your cholesterol suddenly changes and you are on the estrogen pill that you just swallow, I don't mean the birth control pill, I mean just the capsule of estrogen, then this is probably the reason why. Number 3, it's a whole category of topical. When we talked about patches, but this is like your gels, your creams, your sprays that are available at traditional pharmacies, but then we can also compound the gels and the creams. And I should say we can compound the oral estrogen as well. But the oral estrogen is very common at pharmacies, like super common. So going back to number 3, gels, creams, and sprays. So a common gel you might see is like Estrogel. So Estrogel is 1.25 milligrams per pump. The mist is called Evamist, and it's this, it kind of almost looks like crazy, kind of like asthma inhaler thing that you put on your skin and then it mists out. So then you rub it into your skin. That one's a little bit higher. That's 1.53 milligrams per spray. And then there are other options that are out there. So absorption of anything topical depends a lot on you. So it depends a lot on like your skin type, like if you have issues with permeability, like really dry skin, really oily skin. Do you have a lot of fat under your skin? Do you have very thin skin? Did you put lotion on or sunscreen on before you put your estrogen cream, gel, or mist on? All of these will impact ability to absorb. What I didn't say with the estrogen patch, going back to that, which I should, is these same things apply. So if you've applied a lot of lotion, you got out of the shower and forgot, put all this lotion and oil on, and then try to apply your patch, you may find it doesn't absorb as well or the adhesive doesn't stick as well. But I think this is common sense with anything topical. If you've done a whole bunch of stuff topical beforehand, it's going to impact the absorption. Now, the alcohol-based gels tend to absorb a little bit better. So if your prescriber suggests an alcohol-based gel as opposed to like compounding a cream, this is why, because the absorption's a little bit higher. Anything topical, gel, cream, or spray, we do have to be careful of transferring it to other people. You don't have to worry about with the patch. You don't have to worry about that with the capsule. But anything topical, if you rub it on your arm or your thigh or your abdomen, and then you come in contact, you pick up your dog, you pick up your kid, you hug your partner, maybe you put your estrogen on before bed because you don't like night sweats at night or you want to sleep better, and then you're snuggling your partner, you co-sleep with kids because you still have little kids, your cat snuggles down in there, you could transfer it. So you have to be very careful. You want to make sure you apply it earlier, rub it in really well, let it fully absorb, or at least wherever you put it on, make sure you have some sort of clothing covering it, like your pajamas, or if you apply it in the morning, whatever it is in the day. So, and this even applies to your job. It doesn't have to apply to your family. I have had vet techs as an example. They put their estrogen on, they go to work in their short sleeve scrubs, and then they're touching and picking up animals all day, and they can also transfer the estrogen to them. Trainers put their estrogen on, they go to the gym, then they sweat it out. They're like helping their clients, they're on machines. It's possible that you could just transfer it. So you want to make sure you rub it in really well and let it absorb. All right, number 4 is injectable. So there are 2 types. We have what's called IM or intramuscular, which is generally done once a month. And, that's a big needle. Or there's sub-Q, which is subcutaneous, so smaller needle, tinier amount, and it's generally done weekly or maybe even 2 times a week. Not as common, but it is becoming more popular. I am seeing the sub-Q more and more and more because women aren't liking to swallow estrogen. They don't want those side effects. They don't want the topical because they don't want to transfer it to anybody. They don't love the patch because they have adhesive allergies or it slips sliding around when they go to the gym or swim or whatever in this summer. But they like the idea of injectable because it's a little tiny needle. They do it like once or twice a week, and then it's in the system and less side effects. So I want to put that out there that there's not a lot on social media around injectable, but it is becoming more popular, specifically that sub-Q. Number 5, the sublingual troche, sometimes pronounced troche. Basically, it looks like a mint. It's estrogen and a little dissolvable thing that you put under your tongue or up against your gum, like lower lip and your gum, and just let it dissolve. Now, it's pretty small. It can usually be flavored. And this is compounded. This one you are not going to find at your everyday pharmacy. You won't find this at like the big box stores or Walgreens or CVS or Kroger or anything like that. This one has to be compounded, and it can be mixed with other hormones. So you may have estrogen and testosterone, or estrogen, testosterone, and DHEA in a troche, for example. The downside to troche is that while a lot absorbs through your gums, so you get it in right away, you do swallow some. So you have still the little bit of risk, such as the capsule. So gallbladder disease, clot risk, the cholesterol changes, binding globulins, not as much. But if you've ever had a mint in your mouth, you know that you're swallowing that peppermint flavor right down in your saliva. Or at some point, sometimes you're like, I am done with this mint. I'm going to crunch it and just swallow the rest of it because it's like driving me crazy. And again, so now it's this hybrid of like some of it gets absorbed in your gums right into your system and some of it gets swallowed. But some women really like it because, again, it is a little bit of hybrid. So it's easy to do. It can be custom dosed just for you because it's compounded, but we do have to watch out for some of those side effects. That leads me to number 6. Number 6 is systemic vaginal estrogen. Now, we talk all the time about low-dose vaginal estrogen. That's actually going to be number 8. We're not there yet. But systemic vaginal. So there are options. We can compound it to be a full systemic dose. You can get something called a ring, an estrogen ring that give you a systemic dose. The systemic vaginal isn't quite as common. I don't see that quite as common unless you're having all sorts of side effects with everything else, because most women don't want the goopiness of it sliding out vaginally. Most women are like, like every night, really? Like this is a lot to put up there. And then if you are intimate, you have to be careful not to necessarily get all your systemic vaginal hormone on your partner. But it is definitely an option to do and covers the vaginal symptoms as well. So it is a twofer. You get the symptoms systemically, but then also if you're having pain with sex or any kind of dryness or atrophy, which is thinning and shrinkage of the tissue, then this is a really nice option. And we can compound it with other hormones. So you could do vaginal estrogen and progesterone, or vaginal estrogen and testosterone, or all three. We can really make it for what you need. And it's not a lot of hormone. Don't think that, oh my gosh, because it's systemic, it must be like a half a cup is shoved up there. No. It's a very, very small amount that can be made. They can even make it in what's called a suppository, like a beeswax based or vitamin E based thing that gets inserted up there. But number 6, this systemic vaginal. That leads me to number 7. We're not quite to the low dose vaginal. Number 7 is the pellet. Now the pellet is really controversial. I'm fully aware. I am personally not pellet trained, but I have some good friends that are incredibly well pellet trained and do great. Their patients are just so happy. In fact, my old neighbor used to get a testosterone pellet and she called it her battery pack. She's like, I can totally tell when I need more testosterone because my battery runs down to my body. I get the pellet, I motor back up. And I just thought that was the coolest thing. And she is the absolute candidate for it. So what is a pellet? A pellet is like a rice-sized grain of hormone that's inserted into your upper hip area, upper buttock area, and it stays in for about 3 months. Now, once it's in, we can't get it out and I can't adjust it. So if you get it in, whatever dose you do, and then you're like, I don't like this, I can't take it out and replace it with something higher. Well, whoever's trained, I'm not going to do it. I'm not trained. But you do need to keep this in mind. And I don't generally recommend the pellet is the first place you start. If you've never done hormones before, if you're listening to this and you've never even touched an estrogen, don't start with pellet. Like let's use something else like the patch or a gel or something else that we can adjust the dose easily for you. You can get used to it. We can play around with the different routes before you jump to a pellet. If you've been doing estrogen for a long time and you're like, gosh, that'd be so nice to just insert it in my hip and let it run for 3 months, I would love that. Then a pellet might be the right thing for you. It does, depending, last less than 3 months for some people. So if you have a really fast metabolism, I definitely have had people that after about 2 months, 2.5 months, they're like, I'm feeling like I need another one. Like that was faster than I thought. And then I've had other women, it goes like 4 or 5 months. Like they just have this really slow release of the hormone and it lasts longer. But we say on average-ish, it lasts about 3 months. So that's the pellet. Once the pellet is in, like I said, if you do have any side effects, then it's just side effect management because we can't get the pellet out. So that's why on social media, it's also not FDA approved at all. So that's another reason on social media, you kind of see some people who poo-poo it, so to speak. But like I said, in the right woman, like my neighbor, worked wonderfully. Loved it. I know a lot of women who do really well with it. They've been doing hormones for a while. They've dialed in their pellet. They figured it out. Not an issue. So if you think a pellet is a great idea, definitely go to somebody who's been doing it for a long while and is really trained up because, again, once it's in, it's in. That leads me to number 8. Now, number 8, as I said, is the low dose vaginal estrogen. So this is a small dose that doesn't necessarily go systemic, not much, barely, but it's really specific for all the vulvovaginal tissues that you have. So dryness and atrophy and pain and your chronic urinary tract infections and maybe even some mild prolapse, it can help with all that. Lubrication. So that's why we use low-dose vaginal estrogen. So let's say 6 other routes we talked about may not improve the vaginal stuff. So the patch, the pill, the gel cream or spray, the pellet, the injection, like those things may not improve the vaginal. So just because you're on systemic doesn't mean the vaginal is going to get touched. You may have to do both. You may be on a patch and have low-dose vaginal estrogen that you have to use. You may have a pellet and need the low-dose vaginal estrogen. You see what I'm saying? The systemic vaginal usually does take care of the vaginal, because it's location. It's right there. So of course it's going to help you systemically and also make that feel better too. So I have it as number 8 because it's not generally like a systemic option your prescriber is going to suggest, but it is 100% an option they should suggest to you regardless, whether you're on systemic or not. The really nice thing about low-dose vaginal is that, let's say you're not ready for estrogen. Let's say you've been listening to this and you're like, I don't know that I'm ready for estrogen. I'm kind of freaked out by estrogen. The low-dose vaginal estrogen, of course, according to all the guidelines, is generally considered really pretty safe, doesn't really go systemic, doesn't increase risks, doesn't come with a whole lot of side effects, and can be really, really, really good for all things vaginal. Urinary vaginal. So like all those tissues down there can be helpful. So if you're having any of those symptoms, at the very least, I strongly recommend that. And if you are on something systemic, like a patch or a gel or a spray or something, and you're like, what the heck? I still have pain with sex and I still have urinary tract infections, or I feel like things are shrinking down there, it's really dry, then you probably still need the low dose vaginal. The systemic is not working. It's not like, we call it systemic, but it's like clearly not getting to the whole system. That little closed system down there in the vulvovaginal area, it's not getting to. All right. Those are the 8 options. If you have a uterus, and you're on a systemic form of estrogen, you have to be on some form of progesterone or progestin. Just know that a progestin is synthetic. And the reason for this is that the progesterone or progestin reduces the risk big time of something called hyperplasia. Hyperplasia in the uterus is a thickening of the inside of the uterus. And if it gets thick, it can cause a lot of bleeding, and worst case scenario can develop into uterine cancer, also known as endometrial cancer. Endometrium is the inside layer of your uterus. So if that gets really thick and you start noticing spotting and bleeding, and let's say you're fully postmenopausal, we don't want that. I don't want a postmenopausal woman who shouldn't be getting her period all of a sudden to start bleeding or spotting. We want to reduce that risk as much as possible. So this is why, if you're listening to this and your prescriber says, oh, by the way, you also need progesterone or a progestin, this is why. We don't want hyperplasia. We don't want uterine cancer. If you don't have a uterus, let's say you've had a hysterectomy and you're like, not a problem. I had a hysterectomy. I don't need it. Very true. You don't need progesterone. However, do know you have progesterone receptors through your whole body. So you may feel better going on progesterone for the other reasons. Like progesterone can be very calming and soothing and relaxing. It can help with sleep. So if you're having any of those issues, you may find like, yeah, actually, I don't have a uterus, so I don't need to worry about that. But I do have the irritability, the lack of patience, the anger, I probably should use some progesterone. So talk to your prescriber about that, even if you've had a full hysterectomy. All right, side effects we'll touch on briefly. You're on some sort of estrogen patch, gel, spray, injection, pellet, capsule. You're on something. And you're like, okay, warn me, Carrie, what's coming? Well, maybe nothing. You may be on the absolute perfect dose. So let's think positive. I do want to say it does take time. And as you can see, we have 8 options, 7 of which are for what we call systemic or the whole body. So if you don't like the dose you're on, you're having all sorts of side effects, you didn't fail hormones. Don't worry. We just didn't find the right route or the right dose for you. Plus, you even heard with patches, your prescriber might tell you to apply it in the back of your body, but then you feel better. You actually notice a difference when you apply it in your lower abdomen, so the front of your body. So you can see there's a lot of nuance in play. So don't consider yourself not a candidate if the first go round doesn't work or you don't love it. So side effects, bleeding changes. Whether you're perimenopausal and still sometimes get a period, it's pretty normal to get weird bleeding changes like spotting or heavier or lighter, or you get your period twice in a month and then you skip 4 months. That's not uncommon. But if it keeps up after several months, 4 to 6 months where you're like, this is wild, always, no matter what, just always talk to your prescriber. So your first month out, if you're like, whoa, that period was so heavy, what the heck? See what happens the second period. I'm usually like, all right, note to self, heavy period, but let me know about next period. And if the next period levels out, you're like, okay, I'm back to normal. I'm like, cool, you just had to adjust there. But if you're like, no, Carrie, second period, wildly heavy. I'm like, all right, we either have too much of estrogen, not enough progesterone, or something else is going on. If you're post-menopausal, you haven't had a period in 12 plus months, and you start bleeding, you need to let your prescriber know. Usually, it's because you just started estrogen, or maybe you adjusted your route or your dose. But I don't want you to have hyperplasia or, God forbid, worst case scenario, cancer. Now, hyperplasia and cancer don't usually form in the first month, right? Like usually you are on estrogen for a while if this is going to happen. But if you're listening to this and you have been on estrogen for a while and all of a sudden you are like, whoa, I haven't had a period in years and just got a period, always talk to your prescriber so that they can document it and tell you what to do. That's like the most important thing. Other side effects: sore, tender breasts, because we have a lot of estrogen receptors in our breast tissue. So depending on your dose and depending on the route, I tend to see sore, tender breasts, especially with the capsule. If you're swallowing your estrogen, it's kind of a big bolus of estrogen. Or if you start with a patch that's like the 0.1, the highest right away. Like if you jump all in, if your prescriber's like, let's go, let's do estrogen, you're kind of a sensitive bunny, then I will see the sore, tender breast show up right away. Bloating. Estrogen obviously can impact like electrolytes and water retention. So I will see some women like, oh gosh, it took me a couple months to get over the bloating, the water retention. Mood changes. If you're on too much estrogen, you may feel PMSing, where you may be like, I thought I was over that. Now I feel really PMSy again. Again, could be an adjustment, that we need to make an adjustment to either estrogen and or even progesterone. And of course, and then I mentioned the ones earlier with the oral, the capsule, about like gallbladder and clot and things like that. Clot is a big one. Everyone freaks out about clot. Clot predominantly is, the risk is only with the kind that you swallow. So if you're on a gel cream, spray, injectable, the vaginal, the patch, the pellet doesn't seem to increase the risk of clot. It's just the kind that you swallow where you get the slight increased risk of clot. Woo! We covered a lot. There are a lot of options. 8 options for estrogen. So now, hopefully, this helps you decide when you're ready for estrogen, or if you're on estrogen, or your prescriber suggested estrogen and gave you a particular option, why they gave you that, or what to talk to your prescriber about. If you're having any of these side effects, always talk to your prescriber. Even your pharmacist, use your pharmacist. They're a wealth of information, because I know hormones like estrogen in particular feels like herding cats, and I'm here to help.